Hello, thank you for inviting us to speak. My name's Katie Lansdale. I'm a director for PPL, and we are a social enterprise that provides management consultancy support to a number of health and care projects. We've been working in Surrey for some time. I should start by saying that I'm very much not the hero of this story. Unfortunately, the heroes of this story can't be here today. They're out there healing the sick still. So I'm here to present on behalf of the team. And the rest of the team comes from Surrey Heartlands, and within that, the place of Surrey Downs. Surrey Heartlands was one of the first ICSs in the country, and we've been working with them for some time, supporting the work that they've been doing. If you cast your minds back to the start of the pandemic in early April 2020, we were all expecting a surge in COVID patients, which would put pressure on our systems. And many places were concerned with the pressure on acute and intensive care beds, which led to the formation of the Nightingale hospitals. In Surrey, NHSE modelling suggested that the capacity gap would be seen around rehabilitation beds instead, and there was a gap of about 300 beds that was expected at that time due to the COVID surge. So a project was put in place to provide step down and step up capacity to plug this gap that could be used for rehabilitation, for convalescence and end of life care. And that required finding a suitable site to provide that on quite rapidly. So there was no existing site locally that was considered suitable, but there was a former military rehabilitation centre called Headley Court in Surrey, and you'll see in the picture that's one of the older buildings. There are some new blocks too, but it's set in the lovely Surrey countryside, very leafy and green, and an excellent site to help people to meet their rehabilitation goals. It was named after Mary Seacole, in contrast to the Nightingales, named after her contemporary, as she focused her practice very much on looking after the whole person and recognising the mental as well as the health gains that were needed for recovery. How did we approach the challenge? Now, creating a new hospital from a standing start is a challenging process and requires multiple strands of work that have to happen while we were getting used to working virtually. So if I think of the other experience I've had of commissioning new hospitals, it's been 6 years building a new building or refurbishing something, a couple of years setting up a new unit with all the planning involved. We had weeks, not years, and we didn't have that existing site with all of the infrastructure that comes with that. So firstly, we really had to focus on the engagement and bringing people along on that journey. So teams had to collaborate virtually, which was new back then, and required us to develop and refine new ways of working. So we drew in clinical experts from geriatric care, general practice, therapy, social care, who could think about what an appropriate clinical model was for a disease that really wasn't very well known at that time. And the team was really focused on using best practice, both in terms of the clinical model, but also how to engage with people that would use the service. We couldn't bring people who might use the service in at that point. So we had to think about different approaches to bring people along on that journey. We supported the development of a model of care, and that was tricky because actually until we opened the doors, that team didn't know anything really about the cohort of people that were going to come through. So that was really challenging. But we had to think about the infection control measures, therapy, pharmacy, mortuary services, and also the patient and family experience. We knew from good practice that patient and family experience was really essential for people to be able to meet the rehabilitation goals that they were going to want to set. We developed a staffing model to ensure that we had the right level of nursing and allied health professional leadership at the centre, and to provide the right kind of skill mix and think about how we could recruit that. we had to attract nurses and professionals to come to work in a new facility on an unproven model of care that had not been set up before. We wrote and delivered a business case to get the funding for this in a few days, and also thought about some of the system governance that would be needed both before and after go live for bringing together all of the partners involved across Surrey and actually beyond who might use this facility. And those relationships at that point weren't really tested in earnest in the way that they have been now. And finally, we looked at implementation planning and making sure that we had a phased approach that recognised the fact that we didn't know quite what the future was going to look like and what was going to come through the door in terms of patients. The C-Call Centre was opened by Matt Hancock on the 4th of May 2020, just 5 weeks after the project began. It provided exactly what it was intended to provide in terms of improved quality of care and improved outcomes for COVID-19 patients. And actually, the rates of discharge to the home environment were higher than anticipated, and some of the rehabilitation gains were also higher than was initially anticipated. And we did successfully reduce pressure on other parts of the system, working together as a system to do that. It's also worth noting that although the facility has since closed, part of its legacy is in the long COVID service in Surrey and Surrey Downs, which uses a lot of the learning and experience from staff from the C-Call Centre. And also that approach of bringing system partners together to commission a new service in a new way was also really important. So finally, in terms of the impact of our work on patient experience, as I said at the beginning, we weren't able to consult with service users before going live, which is obviously what we would have wanted to have done, partly because we didn't know who those service users were going to be, really. So instead, we had to develop a different approach, which was much more flexible and responsive and took patients along with us as the service developed. So it's really about listening to individuals, telling us what they valued from the service, and things like recognising that actually having the opportunity to, rather than take a walk up and down award for those rehabilitation goals, to be able to take a walk out in the countryside around Surrey was really valued, and also being able to be connected back with friends and family was very important. What we tried to develop with that was making sure that we had that flexible and responsive approach, and making sure that we were feeding in all the time what patients were telling us, and staff were listening to that. I'm going to end there. Thank you very much.